My name is Andrew Rampy. I'm a ear, nose, and throat doctor here with the Greenville Hospital System. My group, our group is called Greenville ENT. It's sort of a group of 9 ENT doctors that focus on head and neck surgery. I like to focus on ear surgery. We do a lot of tympanoplasties to fix holes in the eardrum, or surgery to fix chronic ear disease like chronic draining ears. You saw some of that in clinic today. And then cochlear implants, and then other kind of hearing restorative surgery as well. I would say the chronic ear surgeries are probably some of the harder ones that I do. That kind of problem, dealing with that kind of chronic drainage or chronic draining problems in the ear is difficult. You could see all that infected tissue in the mastoid, but the surgeries are difficult and sort of high stress because you're working around important structures, and it's difficult to fix the problems if you have a problem. Like, for instance, if you were to drill into the inner ear or drill into the facial nerve, those are not problems that are easily fixable. You would if you damage the nerve in that way, the patient's never going to recover fully. And so they tend to be kind of high stress surgeries. There's a lot of steps to get the ear open and get the exposure the way you need it, and make sure the room's all set up and get the patient positioned appropriately. You can see with those ear cases are difficult because they involve lots of little tiny picks and instruments. Some of the picks are so tiny that it's hard for the surgical scrub techs to see like what's at the end of this instrument. And it's hard to keep the instrument, like you'll occasionally have an instrument that's supposed to have a little tiny hook on the end or something, and that hook is broken off. But I think one area that will probably be innovated in ear surgery in the near future is the ability to have some stereotactic localization. We do that in the sinuses. We attach a little sensor to the patient's head, and then we use this, we call it a fusion system. You get a CT scan beforehand that's kind of like a blueprint of the inside of the head. You get the anatomic landmarks, and you can see where all the bony structures are. And in the sinuses is especially helpful because you can tell where the orbit is, where the edge of the eye is, and you can tell where the roof of the sinus, which is the floor of the brain. Right now, if I were doing a cochlear implant, you have to drill out the entire mastoid and kind of hollow it all out, and then you drill this narrow space, which is there's a recess between the facial nerve, the nerve that works the face, and this chordotympany nerve, which is comes off the facial nerve and sends a signal to your tongue. But in any event, those form like a little V, and you make a little opening in that V, and then the implant slides through that opening into the cochlea, which is right on the other side. But you're doing all this work to get access to the cochlea, and I think it works most of the time. Is my impression. You just need it to work all the time, and you need it to never hit the facial nerve, right? Because that's something that a human couldn't do. You couldn't there's no way you could know with 0 landmarks exactly how to hit it in exactly the right spot within, because the space in that V is about 3 millimeters wide, and so it's a really narrow, it's a narrow opening, and it's yay far down into the ear. So without having any other landmarks, it's difficult to hit that narrow spot.